Hi, this is Dr. Tim Conley, and I'm going to talk about a case that's being presented here in Module 2. This is a case of Jonathan Santos. The name and the date and a lot of the circumstances, the names of different places have been changed to pretty much to anonymize the case. But this is a guy I worked with about 2 years ago, I think, and a very educational case, a good case for teaching given what we have been reading for this module. So I'm going to go through the case. You might want to follow through as we look at it. Now, this guy was seen for 5 hours of assessment and eval, and most important to note, the consent forms were signed for parole and probation and Office of Public Defender. So in this case, he was court-ordered, mandated. They said get an eval. He had been under the care or under the supervision of one legal entity or another for roughly the past 10 years, from age 20 to 30. He seemed to be getting tired of it. One thing that comes up in the background information, his mom was about 13 when she had him, and not a big age difference here. He was kind of self-conscious about that. He expected me to ask more questions. He said that rather provocatively, like everybody I tell that to then wants all the details. I didn't see the importance of knowing any more of the family history. He has 4 sisters, 3 kids of his own. That was the most important thing. Sometimes a client will put out I don't want to say red herring, but a sort of an oh wow fact of their life especially if they've been around a while. I'm not his first counselor. I'm not the first person he ever gave sort of background information to. And he's learned over time, perhaps, I don't know, consciously, unconsciously, if he throws out these oh wow facts, it will pull the counselor off track. And, in a 60-minute hour, if you spend 7 to 10 minutes talking about his family history, well, that's, 7 to 10 less that you're going to spend talking about his substance use history and the current symptomatology. So, especially with someone, if they're in the correctional system, if for some reason you suspect that there may be some level of manipulation there, or what we call access to, cluster B personality stuff, can be very hard to keep on track. I always have my guard up when I'm working with, correctional folks who may have had a history of manipulation. And I suspected that with him. Very charming, very likable. But on the other hand, sometimes very difficult to keep on track. Now, it didn't turn out to be that difficult to keep him on track. I moved right past the my mom was 13 when she had me thing. I moved right past that into other stuff, and he didn't pull me back. He didn't get an attitude like, don't you want to know about my mom? Or don't you understand what it's like to be born to somebody at that age? He didn't, I've had those kinds of diversionary dialogues come at me quite a bit in working with the correctional population, but he didn't. We were able to actually move through his history pretty quickly. I had gotten a little bit of it from his probation officer. Again, consent forms are key. You cannot even acknowledge that you know the client. If somebody calls, I got a call this morning on another case that I used to work on 2 years ago with the Board of Professional Nursing, somebody I assessed for them for having a substance use problem. The attorney calls me up, hi, I want to talk about so-and-so, blah, 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 blah. First thing out of my mouth, do you have a signed consent form, and can you get it to my desk before we say anything? I just need to know that you saw her. I can't tell you that I saw her. The attorney didn't say that, but sometimes they will. People will really push into that kind of thing. If the client, I don't want to digress here, but if the client is sitting right there in the room with the person who's calling, gets on the phone and says, yeah, go ahead and send my record over, I will go ahead and send the record over. Do I have a consent form? No. Can I put a clinical note down in my file afterwards? Spoke with client by phone as she sat in her attorney's office, and she indicated that I was to send the record over, so I did. That's consent. You're not going to get in trouble for that kind of thing. You do want a paper consent form, though. But a lawyer calls you out of the blue, or probation calls you out of the blue. Hey, did so-and-so come and see you like I told them? I don't know. I'd have to have a consent form to disclose that. So be careful with that. At any rate, all the proper consents were informed. Let's look at his chemical use assessment and testing. He went 11 for 11. A couple of different checklists, went through that pretty quick. You can see that he was elevated on drug abuse screening tests, above the cut point. No alcohol, primarily methamphetamine, primarily amphetamine type drugs, mood altering type drugs. He's used marijuana, bath salts as well. Has a history of IV injection of methamphetamine. Um, I didn't spell out what the bath salts were, but given the reading that you did recently, what is up with that? Was that overlooked? Did I minimize that? Perhaps the clinician should have looked a little bit further at what that was and what that meant. Mental health assessment and testing, we had to be very thorough to do a co-occurring assessment here to look for both mental health and substance use, of which he was showing both. When you look at his elevated levels on the depression and anxiety scales, very high. In fact, his level of mood impairment between the anxiety and the depression made it difficult for him to participate in the evaluation. I've had people who were just too depressed to go on. They could not answer the questions. Let's see. Oh, that's where the topic, the word flailing came up. Bottom paragraph there. Talked about flailing. That was a new word to me at the time. I had heard of tweaking, and I'd heard of, uh, zoning out and different street terms, but I hadn't used flailing. It took a while for that one to stick with me, and then he explained what it was, and it's what we used to call tweaking. He had paranoid ideation. Sometimes it would just have this overwhelming feeling of they are right there. They're coming. They're going to get me, and he's got to go. And he would run. He would actually run to the police station and say that he was going to be assaulted, at which point the police would, say, is this real, or, is this a mental health problem? And it clearly with him was parapsychosis. Let's go down into his dimensional assessment. At this point in Addiction 2, you're all familiar with the ASAM dimensional assessment. And on him, if you look at his, Dimension 1, he was likely to be in withdrawal. I couldn't tell if he was withdrawing. The mood stuff, he looked very uncomfortable. He couldn't sit still. He was very shifty. Looked like a lot of things were just kind of hurting. His recommendation was for inpatient. We're going to get to the major ethical dilemma of the case in a second. Also, he had a fungal infection under his skin. You look at the biomedical conditions and complications. Don't know where that came from. I suspect that it was an injection-related infection. It was causing discoloration. It was being treated, but it wasn't working. He showed up in the ER with stomach and flu-like symptoms. I suspect it was withdrawal syndrome stuff, but it's important to note if somebody has, an infection or an untreated broken limb or anything like that, you put that down on the dimension. The key term in the Dimension 3 was pathologically elevated levels of anxiety, depression, and intermittent parapsychosis, likely secondary to substance use. That kind of says it all. Have to be sure to put that right there. He was having a major mental health break, some breaks with reality. What could have been misdiagnosed as, say, paranoid schizophrenia. I had to differentially diagnose that from a straight up schizophrenia with paranoid, features. So, but I'm pretty sure it's secondary to his substance use. But we won't know until he gets into level 3-7 clinically monitored intensive inpatient service so that we can get a full psychiatric workup. That was the final word on the assessment there. We need to have him sit still and get a good long look at him. That was not likely to happen outside of the correctional system. That was the ethical dilemma. So, real important piece here I want to point out for you guys on Dimension 4. Very convinced that the substances which are causing him problems will solve them, and that can be I don't want to say typical or common, but you know it when you see it. Clients are like, no, it's the only thing that keeps me going. If I didn't have meth, I'd never make it to work. If I didn't have an opioid, I'd never recover from the meth that lets me make it to work. I have to do drugs or everything's going to fall apart, when it's exactly the opposite. Everything is falling apart because the individual's doing drugs. We don't want to confront them on that. You've just got to go, looks like the best thing you got going for you is the substances. Is that working? What's up with what's the long term on that? Is this going to work? You're going to continue to use substances, and where's it going? He'll come to his own conclusion. This can't go on. They'll figure that, and he did. He had a larger existential sense that this stuff has to stop. He's very self-deceiving in the past, and again, that's common with addiction. This isn't as bad as I think it is. Yeah, it is. that I had that on continued use. Potentially, he had a lifestyle issue going on, um, and he was willing to commit to a longer course of treatment. Tell you in one more minute what we were angling for. Oh, good. I'm down to recovery environment was not good. He had very few straight people in his life. His girlfriend used. He lived in a motel. He was on the edge. He essentially was kind of homeless and transient in terms of where he would stay. Um, the what we were really angling for with him was a felony conviction. The best thing that could happen with him is he would be convicted of a felony for the methamphetamine. The reason that's the best thing, it's never good to have a felony on your record, but it was the only ticket into residential treatment that he had. There was not going to be any publicly funded, residential treatment for him, inpatient, beyond emergency room trips. It just was not available. No health insurance, waiting list, 300 people long at the only place that he stood a shot at getting into. Though he belonged on those waiting lists, he should. But the better program was going to be a level 3-5, actually, residential methamphetamine treatment program run by the Department of Corrections, but you had to be on a 5-year DOC Department of Corrections commit to get it. And that really was going to be the best thing for him. I put down on the impressions a personable and likable character. What am I going to say? Oh, he was very unpersonable and difficult to like? No. But you can say, let's say that he had presented a little bit differently, like earlier started saying, why don't you want to know about my family, and kind of, being aggressive and stuff. I could say, let's see, what would be the would be the clinically proper way to put that. Mr. Santos proved to be very challenging to interview, his demeanor was marked by oppositional and defiant communication, period. And find different ways to say he, was disagreeable, difficult to get information out of, et cetera, et cetera. But nonetheless, he wasn't. He was personable. He was likable. He had a little charm going for him. He was not using that charm to try to manipulate me. He was developing an increasing level of insight, but he was just too disorganized to take the action steps necessary. He just couldn't make a plan and follow it and follow through on the day. By the end of the day, he just couldn't even. It's not where he thought he was going to wind up, and he usually wound up back using substances. 3 of the last 10 years of his life in county detention, but no prison, because he avoided the felony conviction. So he spent long amounts of time. People didn't want him out. Oftentimes they'd be like, "You're just going to stay in jail," and they found ways for brief jail sentences under a year, so that he stayed in the jail where there are no services where we live. So he sort of was caught in this cycle that we hope to get him out of. I was pushing for, the relevant attorneys in the Department of Correction and Probation to just push for the felony conviction to get him into the DOC system where there were some treatment options available. So that's Santos. So what I would ask you, and I think I have on the written questions for this case, of what you read, is this typical? Is this what methamphetamine does to you? What's up with the bath salts? I didn't really explore that much. What's going on there? And, do you have a sense, perhaps, that his psychosis was, in fact, drug-induced? Was it going to be there if the drugs go away? At any rate, good case to share with you guys, and look forward to your discussion this module.